Hello everyone, welcome to this session of the ADI conference in which we're going to have an overview of the STRiDE project. The STRiDE is the acronym for Strengthening Responses to Dementia in Developing Countries. I am Adelina Comas-Herrera, I'm co-lead of the project, and I work at the London School of Economics. So it's my pleasure to introduce this session and this project. STRiDE is a 4-year research capacity building program funded by the UK's Global Challenges Research Fund. Our aim is to synthesize and generate policy relevant evidence to support the development of policies to respond to dementia. What we do in terms of what type of research it is, what we call it formative research to inform dementia policies. And we've provided the website of our project where you can find out more, and you can also find us on Twitter at STRiDE Dementia. STRiDE at the moment is happening in the countries in red. If we are in Mexico, we're in the little dot that you can see near Mexico, that's Jamaica. Also in Brazil, which takes up a lot of the screen. We're also in South Africa, Kenya, India, in Indonesia. We're also now starting we've got some parallel projects happening in Hong Kong and some communities Chinese communities in Romania, Switzerland, New Zealand, and we've been discussing with colleagues in Chile, Peru, and Malaysia about potential link projects. We are a collection of people, so we have lots of institutions involved. We are a mixture of academics and NGOs, and we also have developing strong links with policy advisors, with groups like institutions like WHO, the Inter-American Development Bank, Asian Development Bank, Help Age International, and we're also trying to work very closely with national governments. And I'm not going to read every one of these institutions, but we really appreciate the work with everyone. This is a slide that gives an overview of what is a very complex and rich project. And don't worry about trying to read all these, but we are very much bringing together lots of different types of information and trying to generate an understanding of what we have in each of the countries in which STRiDE is working in terms of the care, treatment, and support of people with dementia. Try to understand what's the evidence of what works, what are the aspirations of the stakeholders, the people involved, in terms of trying to improve the systems, and then trying to understand what we'll need to have in place so that we have better care, treatment, and support for people with dementia that meets their aspirations and the aspirations of the stakeholders by 2035. We will now want to know how much this will cost, what will be the workforce requirements, and also what are the reforms, policies that need to be generated in order for this reality, a better reality in terms of the care, treatment, and support of people with dementia to be a reality. And we will, of course, conclude the project with policy recommendations. We are working in partnership with Alzheimer's Disease International. As I said, this is a collaboration between academics, NGOs, and we're working very closely with policy partners in government and other organizations. So I'm going to now introduce our speakers today. First of all, we're going to hear from Saadiya Hurzuk from India, who will be telling us about including people with dementia in planning for dementia, theory of change workshops in India. Then Christine Musyimi was going to tell us a bit about some of the stigma-related work they've been doing in Kenya. Specifically, she'll talk about barriers to dementia care in rural Kenya and how this is affected by stigma. Marissa Stubbs from Jamaica will tell us about lessons learned in preparing for qualitative field work with unpaid family carers in Jamaica. Then we'll hear from Roxanne Jacobs from South Africa on the cross-cultural adaptations of the STRiDE toolkit. We're aiming to generate prevalence, impact, and dementia care cost estimates in South Africa. Claudia Astudillo-Garcia from Mexico will present an overview of the evidence on dementia epidemiology in Mexico. Fabiana from Brazil will present on mapping the provision of dementia care in Brazil. And finally, Imelda Theresia from Indonesia will present an analysis of dementia policy stakeholders in Indonesia. Between them, you're going to get a bit of a tour of all these different aspects of the project, and very exciting to hear what my colleagues have to say. Thank you very much. And we're going to start with Saadiya. Saadiya, the floor is yours. You have 10 minutes.
Hello, everyone. Yeah, thank you, Adelina. I'm Saadiya Hurzuk from STRiDE India team, and I'm going to present today about including people living with dementia in planning for dementia using theory of change workshops in India, a STRiDE initiative. So dementia in India, India has about 5.3 million people living with dementia currently. In 2015, the World Alzheimer's Report stated that there are 58% of people living with dementia in LMICs, which is going to rise to 68% by 2050. In India, the number of people living with dementia is projected to increase by 7.61 million by 2030 and 14.32 million by 2015. Other than that, the other challenge that we face is only 10% of people with dementia in India ever gets any diagnosis, treatment, or any care. Theory of Change workshop, STRiDE India, it happened in 14th and 15th June 2018 in NIMHANS, which is National Institute of Mental Health and Neurosciences, Bangalore, which is the southern part of India. TOC brought together 40 stakeholders from different regions and various facilities related to dementia, such as people who are in medical field, neurologists, psychiatrists, government officials, caregivers, people with dementia, NGO service providers, and so on. For the first time in the Indian context, dementia care was discussed at such a vast platform. This meeting discussed a lot about the outcomes with respect to dementia awareness, terminology, inclusiveness in society, how to get dementia early diagnosis, caregiving, service providing, and so on. So what was the aim for the theory of change? We aim to develop the development of research and training agenda specific to India, building on the expertise of national NGO partners, national stakeholders, which included people with dementia and caregivers, and the UK researchers and national researchers. So what were the objectives of STRiDE India that we worked on? So mainly to develop TOC map outlining impact care pathways to improve quality of life of people with dementia. The objective was to build the capacity of TOC development. The objective was to ensure buy-in and knowledge exchange, to identify the gaps that are there in dementia care, to identify indicators for success, and to develop a monitoring and evaluation framework to measure these outcomes in STRiDE India. So we saw some successes, and those were very promising. TOC initiated collaboration among various stakeholders beyond the STRiDE project. It identified two main issues which were relevant to India: the traditional societies in elderly care and the major socio-economic impact of dementia, highlighting unpaid dementia care. It also highlighted on unpaid care and the need to implement social security benefits in India. It showed how it strengthened formulation of ARDSI Dementia India strategy that was presented in 2018, which was inspired from WHO's Global Action Plan. One of the successes was it was able to define through consensus the expected impact that people with dementia are able to live well and their family, carers, and societies are protected from excessive cost and health problems. It was for the first time in this workshop that a person with dementia and the family caregiver was involved, and they contributed valuable perspective to this discussion. So how did we do this? This was, as I mentioned, that it was for the first time that we involved a person with dementia on such a vast scale discussion. So a neurologist from the STRiDE India group identified the person with dementia for this meeting. a person who is in early stages of dementia, someone who had good insight and good communication skills. The primary caregiver of this person with dementia, who is also the spouse, was invited to the TOC workshop and also represented as the caregiver in the meeting. Consent was taken from the person and the caregiver. To ensure their confidentiality and the well-being, a psychologist was made to sit very close to them to monitor their reactions and encourage the participation in this discussion. Why was this for the first time with us? It is generally perceived that people with dementia are incapable of expressing their opinions or their experience due to communication disability and due to cognitive deficits. Difficulty to identify early diagnosis, of course, because we have poor diagnosis rates and awareness of dementia in the country. Family makes most of the decisions for a person with dementia, and they don't want them to be labeled with the dementia-related stigma. There is a need for platform that we realize. There is a need for acceptance that the people with dementia are capable of representing themselves, and there's a need that these people have prior dementia awareness before their diagnosis. This is the map that was developed after the TOC workshop. And there are some assumptions and the outcomes that we posted over here. So one of the assumptions over here was persons with dementia are recognized as experts in own care and as productive members of society. At the same time, one of the outcomes that we got over here was persons with dementia and caregivers live with dignity and have a good quality of life. So the key outcomes that were observed over here, the highlights of the TOC was that there should be early diagnosis, management, there should be early detection of dementia, national policy, terminology, unpaid care. These were the key outcomes, some of the key outcomes that were discussed. It was highlighted that the evidence gap related to unpaid care and stigma has to be worked on. Moreover, providing a model for the inclusion of people living with dementia and their carers in planning and policy discussion in India. Some more key outcomes of TOC was the person with dementia and their the carer provided valuable contribution to this discussion. The person with dementia mentioned, he stated that persons with dementia should live a life of dignity. And that was a very strong statement that gave and shaped the outcome of TOC. It was concluded and agreed by the various stakeholders that people with dementia should be involved in such meetings. It also taught us that dementia patients can have a say of their own in the early stages, and we should, in future, include them in such meetings. Thank you.
Thank you very much, Saadiya. That was very clear and fantastic. Very good to understand this situation. So I'm delighted to introduce our next speaker. This is going to be Christine Musyimi from Kenya, who's going to talk to us about barriers to dementia care in Kenya. You've got 10 minutes. The floor is yours, Christine.
Thank you, Adelina. Can you see the screen?
Yes, very well. Thank you.
Great. Thank you for the introductions. I'm going to be presenting on barriers to dementia care in rural Kenya, and I'll be presenting some of the findings from the STRiDE project. And just to give an overview of dementia care globally in Kenya, there's evidence and statistics show that globally, there's a new case of dementia after every 3 seconds. And this translates to about 28,000 or 800,000 cases of dementia in a day. And the prevalence of dementia is almost 6% in Africa for those that are above 60 years and above. Although in Kenya there is no national prevalence on dementia, there was a study that revealed that the total number of deaths that were attributed to dementia had increased between the years 1990 to 2016, and this was by 15%. In Kenya, there is also late identification or detection of dementia. So people with dementia often receive their diagnosis late after the onset of the disease. And so based on this background, we sought to explore the barriers to detection and treatment of dementia so that it can provide a basis on how to develop services or appropriate services to enhance access to formal care for persons with dementia and their families. And so we conducted a qualitative study. We interviewed a total of 43 participants in a rural county, Makueni County in Kenya. And we had focus group discussions and key informant interviews. We had 2 focus group discussions with clinicians. We included psychologists, psychiatric nurses, social workers, medical officers, and clinical officers. And so we had a group of 2 discussions among the clinicians. We also had 2 focus group discussions with the general public, and this included the formal and the informal sector. The informal sector included people that are not permanently employed, that are on contract. We had traditional healers, faith healers, people are on business. So we had views from the different stakeholders in community settings. We also interviewed key carers of persons with dementia. We had, we conducted 1 focus group discussions, and because we had to hear views from participants who could not participate in focus group discussions, we had at least 5 carers participating in individual interviews. We also had, after collecting the data, we transcribed and translated and used inductive thematic analysis to report our findings. And our findings revealed 2 main barriers related to, we categorized them into 2 areas. In terms of barriers in access to care, we had the community barriers, and the second category is about health system barrier. For this slide, I'll be sharing on the community barriers that we found in our study. And one of the common barriers that came out very clearly from participants was public stigma and misconceptions. So participants, the general public, carers, and clinicians all had this attribution of dementia to witchcraft, or it is part of the normal aging process. And there were also negative local interpretations where the dementia term was considered abusive, and sometimes it was not an acceptable term, and people felt the community members needed to identify a term that was appropriate within that community setting. And one of the participants mentioned that there are rumors and misconceptions about dementia and other mental illnesses, and especially in this community, people think that it is purely witchcraft. And unless we demystify that, we may not achieve as much in terms of dementia treatment. The other something that came up was around family neglect, and this was related to lack of finances or financial constraints related to hiring a paid carer, or in areas where a carer was not available because of the magnitude of the role of providing care for a person with dementia. And so a healthcare worker stated that we've had cases of patients who've been left alone by caregivers and are actually sexually abused. And because caregivers are not there, the perpetrators just escape. So this leaves a barrier that, if we are not able to address it, then it's likely to hinder access to care within community settings. And then something very clearly that we had from the carers was around denial. Participants considered this dementia as not an African disease, but rather a European disease. And so they imagined this could not be affecting us, and that this prevented them from accessing care because they imagine this is not our disease, this is not something that needs to be facing Africans. But at the end of the day, they were still not going for care. And lastly, the last community barrier that came out from different, and particularly the carers who are accessing services in public health facilities. They mentioned that there was lack of confidence in healthcare services provided, in health services provided in public healthcare settings, and oftentimes they will seek a different opinion in Nairobi, and this will be in a private clinic. The second category was around health system barriers, and we had sub-themes ranging from policy documents, lack of knowledge, inadequate staff, and inadequate supply of medication. So policy documents such as the National Dementia Plan and Policy are lacking. There are also no evidence-based guidelines to guide the healthcare workers to address dementia issues, and we are talking about integration. Note that we have the MH gap, but this has not been integrated within the healthcare system because it has a component of dementia care. We also had lack of knowledge on dementia care, and we had participants from community settings, people from the general public, and carers stating that they were not able to access any information on dementia care and where to access dementia care. And from the healthcare workers, they did not have prior training strictly on dementia care. We also had issues of inadequate staff on dementia care in primary healthcare settings, and this was mostly stated by healthcare workers, and one of the healthcare workers mentioned that very few staff are trained on mental health care, and particularly on dementia. And lastly, in terms of health system barrier, there was inadequate supply of medication. You'd realize when the prescription that was done, carers or families were not able to buy the medication because it was expensive, or if the medication, the basic medications were available at the health facility, the primary healthcare workers did not know how to administer them. So just I'd like to share key messages to take home based on these findings, that it is important to develop policies and adapt guidelines that are evidence-based, which is important to strengthen our community health systems, our health systems, not just in Kenya, but in other low resource settings. And then we also need to improve the quality of care in public health facilities, and this can be done through training, which will increase access to dementia care. Stigma reduction is also quite very important, and this is a stigma linked to dementia, so that we improve early detection and management of dementia. And one of the things that we could do as a country and in these settings is to use awareness campaigns and use dementia-friendly language to reduce any negative local interpretations of the term dementia, to reduce denial and misconceptions, as well as neglect within families and even at the hospital settings. So that's for further reading. You can reach us on our website. You can read about us, email us, follow us on Twitter, and thank you very much.
Thank you very much, Christine. Excellent presentation. So our next speaker is Marissa Stubbs from Jamaica. Marissa, when you're ready, you can share your screen. Excellent.
So greetings, everyone. My name is Marissa, and I'll be representing the Jamaica team today. And I'll be speaking about the lessons learned preparing for qualitative field work with unpaid family carers in Jamaica. So today we'll review the background, methods, findings, and conclusions that arose from our reflections on some of the challenges that came up as we began to prepare to carry out Work Package 4 for the STRiDE project. So the increased demand to provide dementia care among a rapidly aging population is expected to add considerable strain to Jamaica's already overburdened health system, showcasing why research is needed to truly get a sense of the costs and consequences of providing unpaid care for persons living with dementia. And just to clarify, these costs are more than just economic. We also want to get a sense of what social, emotional, and health costs are involved in dementia care. And given that there's a need to identify what dementia care support provisions are required in our respective populations, we first need to understand the gaps in support that do exist. As the first STRiDE country team to undertake WP4 fieldwork, however, there were a few difficulties faced in terms of our timelines and overall readiness. And we understand that this is just due to the complex nature of the STRiDE Dementia project with over 10 work packages and 7 participating country teams. So it's no surprise that despite our best efforts, these delays occurred. So preparation for fieldwork at this scale has and continues to be extensive, but it has revealed strengths and areas for growth when conducting health research that is based on partnerships between developed and developing countries. So this paper presents reflections on the planning of highly iterative fieldwork involving in-depth, unstructured, and semi-structured interviews with unpaid carers of people living with dementia across multiple socioeconomic strata in Jamaica. These reflections were analyzed in an effort to provide commentary that can improve on current research practices and respond to changes in priorities, initiatives, and strategies that contribute to project growth and value. Therefore, analysis focused on identification of things that we can do better, how these things currently impacted the project, as well as suggestions on how we can improve. So now I'll get into the findings. For a multi-country project with multiple packages, it was identified that more time needs to be allocated for fieldwork preparation. In Jamaica, initially WP4 fieldwork was scheduled for just 3 months. However, this proved to not be sufficient time to ensure useful data processes were in place, time for HR issues to be sorted, and for adequate training of research assistants, development of standard operating procedures, or to receive local ethical approval to conduct the study. So what happened is that the time that was originally allocated for field work actually ended up being the time that all the factors previously mentioned took to be completed and finalized. Therefore, that's why we identified that there needed to be more involvement from local researchers when timelines are established, because this dialogue can help to provide the context needed to allow for appropriate planning based on the country context, given that fieldwork in various work packages were originally expected to occur in sequential order. And while this did lead to some delay in fieldwork activities, we found that ultimately this time really helped to ensure that when we did get to the point of conducting fieldwork, we were more prepared. So fieldwork can be high stress and fast paced. So it's recommended that at the start of fieldwork, additional communication channels are implemented, such as having 2 to 3 team meetings between country researchers, work package leads, and project management during the first month of fieldwork activities. This ensures that everyone is on the same page and has an adequate understanding of what is happening and what is expected to happen. It may also require ensuring clearer delegation of roles among local research team members to make clear which tasks fall within each role. And this is going to create a heightened self-awareness and just more mindful communication amongst the country teams. So having clear communication about what was needed, when it was needed, and by whom did contribute to the delay of fieldwork activities as well. However, the improved communications via the meetings really helped with making the necessary adjustments to begin carrying out fieldwork. So for Jamaica, relationship building, we found that this was key during the recruitment process. Relationships with gatekeepers and members of the community are important to guide strategies on reaching populations, especially in the context of Jamaica, where dementia is a diagnosis that is stigmatized. So our team wanted to use a stratified sampling strategy to target those across socioeconomic strata, but we cannot always assume that as researchers, we know best how to reach these groups. So we found that church members and health professionals at health centers became key partners in aiding our recruitment process because our target population already had a trusting relationship with these individuals. And so they are able to introduce the concept of our research to potential participants within the context of this trusting relationship. However, this process in itself, community relationship building, it takes time. And this is because to build relationships with these persons, we as researchers also have to show a genuine willingness to invest in these communities in terms of raising dementia awareness and also sharing information with them. So initially, there was a lack of focus on consistent relationship building, which did impact the diversity of persons initially recruited. However, after sharing just the understanding of the role that gatekeepers play, recruitment strategies really improved and team members became identified as just key stakeholders within the dementia care community. So research assistants have key knowledge about the local landscape. Therefore, it's important to create spaces to allow them to assist in informing data collection through recruitment. In Jamaica, research assistants played a significant role in identifying and building key relationships with gatekeepers, and also identifying which recruitment strategies fit best within the Jamaican context. And we thought that this really helped both the local and UK-based research team members. And we also wanted to suggest that research capacity can also be built by allowing research assistants to gain more information about how data will be analyzed, which can occur through either involving them in analysis or also allowing them to get further exposure to the methodology via methodology reading groups. So continuing with the theme of ensuring open communication channels, collaboration and analysis is also very important. In Jamaica, English and the local language of Patois is spoken. Therefore, we had to identify how best to capture data and maintain its original form and meaning to allow understanding for those outside of the culture, such as those in the UK. And this required some thoughtful thinking. So we, as a full team, we agreed that it would be best to retain the spoken language in the transcripts, whether English or Patois, and just provide translations within the transcript to facilitate understanding during analysis and ensure that we just remain true to the country context. As mentioned before, fieldwork is fast-paced, therefore allowing the space to provide feedback on conducting fieldwork while it's ongoing is important to ensure that we're conducting quality research. This feedback should be allowed from all persons at all levels at varying steps in the research project. And so scheduling regular field debriefings and e-meetings with the field team and the work package team will help to ensure the sustainability of long-term collaboration. Also, having debrief meetings allow for frequent review of the standard operating procedures and ensure that we make adequate adaptations as necessary. So in conclusion, the process of preparing for dementia-related research that involves partnerships between developed and developing countries is complex, but these lessons are relevant to both local and abroad researchers when planning similar research projects. And our experiences emphasize the importance of building equitable partnerships between institutions and researchers, and also between researchers and the population of study, through recognizing the value of local knowledge in helping to collect and interpret data. So through this analysis and continued reflection of the team, we've been able to successfully interview 19 participants with 30 interviews in total. And while the pandemic has resulted in a pause in fieldwork, we've continued to remain in contact with participants, given the identified importance of maintaining relationships and communication in our country context, which will therefore make it easier for us to restart virtual data collection. So I want to say thank you again for listening from the STRiDE Jamaica team, and be sure to follow us on Twitter and Instagram at STRiDE Jamaica.
Thank you very much, Marissa, for this very thoughtful presentation, great reflections. Our next presentation is from South Africa. We have Roxanne Jacobs. And Roxanne, I think you're going to present on the cross-cultural adaptation of the STRiDE toolkit to generate prevalence, impact, and dementia care cost estimates for people with dementia care. Thank you.
Thank you, Adelina. So I'll be talking about the cross-cultural adaptation of the STRiDE toolkit, which is also known as Work Package 5. And this is work that works towards the generation of prevalence, impact, and dementia care cost estimates for South Africa. So just briefly in terms of background, low and middle income countries have poor evidence to support healthcare decision-making. South Africa is no different. Currently in South Africa, there's no routine monitoring and surveillance of dementia. There's also no nationally representative prevalence data. So this is what Work Package 5 of the STRiDE project is trying to bridge this gap, and it's trying to do this through a household survey in generating prevalence, impact, and dementia care cost estimates. So when we're doing a household survey, we need to use tools that are culturally appropriate. So, and because using tools that are developed and validated in other contexts is problematic, translations alone is not enough to actually equal a valid instrument. Therefore, you miss the underlying meanings in a particular setting if you're only focusing on direct translations. So basically, we need to adapt tools across cultures to make sure that they're culturally appropriate. So we're talking about cross-cultural adaptation, and when we talk about this, we're referring to a process that looks at both language translation and cultural adaptation of issues in the process of preparing a questionnaire or tools for their use in another setting. So basically the aim of this particular sub-study was to develop a package of cross-culturally valid instruments for data collection in Indonesia and South Africa. And this is towards that household survey in generating quantitative evidence on the prevalence, the impact and the cost of dementia for individuals living with dementia and their families in these two countries. Now, for the purposes of this presentation, we'll be focusing on the first aim and looking at the experience of South Africa in particular. So our methods, we followed a cross-cultural adaptation process where we tested the cross-cultural appropriateness of the tools, terminology, equivalence, as well as the timing. And we followed a rather rigorous translation process where we had a total of 21 tools that we translated from English to 3 languages in South Africa, namely STRiDE, Afrikaans, isiXhosa. And then we gave the tools, these 21 tools, to 2 independent forward translators in each of the languages. They translated the tools independently and then came together to reconcile the 2 versions. And we did this quite labor intensively, where we compared each item by item, and where there were differences, through discussion and agreement, consensus, came to a 3rd version. This version was then given to another 2 translators who also worked independently and translated from the target language back to English, and followed the same reconciliation process, item by item, comparing them, and then through consensus and discussion, coming up with the back translated version. This is the final version that we used, that we tested in the field, to make basically through cognitive testing. And we did this to assess how items are understood by participants and to identify experiences and the contents individuals were actually considering when they respond to a particular question. We tested this in 2 sites. These are the same 2 target sites that we intend to use for the survey, the bigger survey that will follow. And it was tested in 4 languages, namely STRiDE, English, Afrikaans, and isiXhosa. So in Limpopo is the one province which is our rural site, and the Western Cape represents our more urban locations. In terms of participants, we recruited via our partner organization, Alzheimer's South Africa, also through other NGOs like Dementia South Africa and community forums. And we conducted the interviews at luncheon clubs, daycare centers for older persons, and home visitations. Our participants, we had about 62 participants, of which 35 were older adults and 27 were carers, and most of them were women. In terms of what we found, there's quite a duplication in topics and questions. We were often confronted by participants asking us, we've asked me this already or answered that already, so there's quite a bit of duplication. We had a 90-minute time allowance for the interviews, but we discovered we had way too many questions and we never really completed the entire toolkit with one particular person. So we had to split the batches, and then we looked at the minimum times and the maximum times, and then calculated that our older adult toolkit took about 97 to 257 minutes, whereas our informant toolkit took between 80 and 264 minutes. So that was quite exhausting for our participants. It's about 4.5 hours, which is not practical. So in terms of testing the equivalence in the concepts, we found that there were a few instances where there were inequivalent terms in the languages, and where there wasn't concepts that we could translate, we used descriptions to capture the meaning as close as possible. And I'll say a little bit more about this now, go into more detail. For the isiXhosa and the STRiDE languages, there wasn't an equivalent term for dementia. For isiXhosa, the translators basically used the description memory problems in old age, which we found problematic quite early on because using the term old age is quite stereotyping, and we changed that to memory problems instead. For STRiDE, the translators used brain disease in the translations, and quite early on during the pre-testing we discovered that the actual interpretation from participants were mental illness instead, and we changed the wording to suit memory problems as well to describe that instead. This was the closest we could get in terms of describing dementia in these two languages. For Afrikaans, there was one term that we couldn't find an equivalent for. This is the concept of feeling distressed. The closest we could get in Afrikaans literally means upsetting. For isiXhosa, there was a term for privacy, but the participants couldn't really relate to the term because it's not something that's used in daily conversation. So the idea there is to use the English term privacy to support, at least give context to the question. For depression, there was a term that is basically synonymous to stress. So this is used interchangeably. Stress and depression in isiXhosa is understood as the same thing. And the only way we could make sure that the participant understood the intended meaning of depression is to actually use the English term alongside as well. So some of the lessons learned, we discovered quite earlier on that there's quite significant space issues, especially with home visits. And in instances where carers there were more than one carer in a situation, we found sometimes that they wanted to be interviewed together. So this gave us basically prepared us for what to expect when we go into the field doing the household survey, and it will inform our data collection standard operating procedures going forward. In terms of our field worker training for the pre-testing, we found that this actually enhanced our translation process because understanding the context of the questions, they could help make sure that the translations were in line with the context-appropriate responses. In terms of the liquor type options, we found to be a little bit problematic, and for our participants to recall the options that are available for the various tools, because the various tools had different ones, so it caused a lot of delay in responses. So what we found quite useful is to actually have these prompt cards with the response options on, handing it to the participant for the particular tool, and that kind of speed things up, and we found that it actually shortens the administration time using these prompt cards. And of course, we had to shorten the toolkit. Where it was possible, you used abridged versions, for example, the stigma questionnaire, and we eliminated the duplication questions and cut non-essential tools to shorten. So in essence, we removed items, we edited items, we added items, specifically also to pick up on some of the information that we'd like to gather relating to the COVID-19 pandemic. So in essence, we reduced the toolkit by about 104 items. And now, with this toolkit, we'll be updating the translations and then uploading it into our software, intending to use the REDCap electronic data collection software. Yeah, and then we'll be ready for phase 3 to actually roll out the household survey. Thank you very much.
Thank you very much, Roxanne. And can't wait to actually see how this moves to the next stages. So our next presentation is from Mexico, and we are going to hear from Claudia Astudillo, who will give us an overview of dementia epidemiology in Mexico. Thank you very much, Claudia. You have 10 minutes.
Thanks to you, Adelina. Hi, everybody. My name is Claudia Astudillo. I'm from Mexico, and we'll share with you an overview of the evidence of dementia epidemiology in Mexico. work is part of a situational analysis in this country, and the objective is to understand the characteristic of people living with dementia in Mexico to implement adequate programs addressing different levels of care, and to give an overview about sociodemographic and clinical characteristics of people with dementia reported in epidemiological studies in this country. In the last year, several population-based studies have been conducted in Mexico, provide estimation of the prevalence of these conditions. We identified 4 studies: the Mexican Health and Aging Study and the National Health and Nutrition Survey in SANUT. Both are representative at a national level and reporting a national prevalence about 6.1 in the Mexican Health and Aging Study and 7.9 in the NSANUT. About the 1066 Dementia Research Project has an urban and a rural samples near to Mexico City, and the survey of the Guadalajara metropolitan area is representative of this city, which is near to the north of the country. The study about the 1066 reported an urban prevalence of 8.6 and in the rural area 8.5. In Guadalajara, the prevalence is about 9.5. But we can see the range of dementia prevalence is different between these studies. Maybe the reason is because the difference between diagnosis criteria. So the profile of dementia in Mexico describes that it's more prevalent in women compared to men. The main risk factor for dementia are diabetes and hypertension, and the educational status is the main preventable risk factor. However, Alzheimer and other dementias represents the 5th main cause of DALY, disability-adjusted life years, in Mexican older people. We don't have routine monitoring systems, and we don't have accurate data is available of the total deaths due to dementia. About the sociodemographic characteristics, variability in the prevalence of dementia by states suggests that a large number of people affected by dementia experience high levels of vulnerability and deprivation. However, disaggregated data by ethnic groups or another important characteristics is not available yet. However, according to the Global Disease Burden Report with data of 2019, we can observe the variability of the incident cases between the states, and which means the variability of condition between different regions of the country. So it's an important condition that we have to describe. So analyzing the context of dementia in Mexico, we have identified some main findings. We don't have medical records of diagnosis, but we have data available for population studies, and data reported are publicly available about comorbidities and other disabilities. However, we don't have systematic collation of quality of life data, and no knowledge at national levels of the use of medication, side effects, and etc. But there are a standard of treatments about dementia in the country, and that is important to say, there are not healthcare programs for dementia, and we don't have long-term care policies. But we have some data about the unpaid care of dependent people in older people with the 1066 in-depth study. And it's important to recognize that in Mexico, most people that not get timely diagnosis and treatment are in the private sector and not reported of data in place. So in conclusion, in Mexico, need for further information in order to provide better estimation of its magnitude, and we need adequate updated information as basis for the development of strategies to support the people living with the illness and their families. And we need routine information systems to address the need of different populations across the country. And it's important to say, and personal opinion about the participating in the STRiDE project gave me to opportunity to understand the impacts of dementia in various cultural, social, and economic contexts, and the opportunity of research and training activities to develop my skills and interpreting, using, and communicate evidence in research in dementia context. And is especially the opportunity to participate with a group of great researchers and experts in this area. So thank you very much. This is our emails and Twitter account. Thanks.
Thank you very much, Claudia. That was great. And our next we go to Brazil, and we're going to hear from Fabiana da Mata, who's going to present on how can we improve the healthcare provided for people with dementia in Brazil, views from policymakers, people with dementia, and their carers.
Hello, everyone. I'm just trying to share my screen. Okay. Thank you very much, Adelina. Hello, everyone. So my name is Fabiana. I'm part of the Brazilian team, and I'm going to present the work entitled Mapping the Provision of Dementia Care in Brazil as part of the Work Package 7. Around 9% of the Brazilian population are aged 65 and over, and more than 2 million people live with dementia in Brazil. These persons may access health and social care through public sector and the private sector. In the public sector, we have the universal health system, which provides health for the whole population, and it's free of charge. We also have the unified social assistance system, which it's free of charge, but it's means tested. In terms of private sector, private health and social care are available for people by paying, when people can pay directly for these services, paying for healthcare providers or through the use of health insurance plans. Although we have health and social care available for the population, very little is known about which and how services are provided and or could be tailored to attend the needs of people living with dementia in Brazil. So the aim of our work is to explore what's currently available for supporting people living with dementia and their family carers in Brazil in terms of health and social care. So to meet this aim, we developed a situation analysis, which is composed of a desk review, a SWOT analysis, some case vignettes, and a general dementia care pathway. Our desk review aimed to understand the available provision of care in Brazil. Then we did a SWOT analysis, in which we wanted to know about the strengths, the weakness, opportunities, and threats in care, health, and social care provision in Brazil, which helped us to identify some shortfalls and strengths in this area. Later, we also developed a case vignettes, which we aimed to include some of the Brazilian diversity and the different realities that we have here in the country. So for each one of the case vignettes, for the creation of them and also for answering each of the vignettes, we tried to include different geographical regions. We considered different socioeconomic levels, status, and we also included family arrangements and different educational levels. And we wanted to answer this question: what's the likely support available for a person living with dementia and their carers? After the vignettes, we developed a general dementia care pathway just to give us a visualization of the steps a person with dementia may take to assess care, health and social care in Brazil. And here we've got one of the vignettes that we developed. This one is a very common situation in Brazil. So I'm gonna read for you and then we are gonna discuss a little bit about this. So Mr. F is in his late 60s. He is from a Black ethnic group and lives with his son's family at the top of an urban slum in Rio de Janeiro, Brazil. Mr. F has diabetes and is insulin dependent. He also has hypertension, arthritis, and chronic pain. Due to all these health issues, Mr. F has increasingly avoided going down the favela hills as the streets are tortuous and have led Mr. F to fall several times in the past. The high levels of violence also prevents Mr. F from getting out and about as he has lost a son during a shooting. Mr. F stays most days on his own, and his daughter, as his son and daughter-in-law are working and his grandchildren are in school. Mr. F feels as if he is a burden to his family, so he tries to avoid complaining to them about his health issues, health needs. He has been feeling different recently, with mood swings, memory lapses, and dizziness. He is really scared about what could happen to him, which has made him feel really upset and lonely for several weeks already. Just to contextualize, we have more than 700,000 people aged 6 and over living in slums in Brazil. So the likely support available for these persons, in this case Mr. F, would be that he would have a delay in recognizing his dementia early symptoms, probably due to the multimorbidity that would mask all these symptoms. He would probably not get regular home-based visits by the primary health care teams because of the difficulty in accessing his home. So he would likely be seen by a GP in the primary care system, then he would be referred to a specialist that would require more exams, further exams, and then it would result in a late diagnosis because all this process would take around 1 year, to be ready. Mr. F would have access to medication, but he wouldn't have access to non-medical treatment. In terms of carers, he would have informal and unpaid care, which would be probably his daughter-in-law, and by the time she would have to quit her job to take care of him. This would negatively affect the family finances. And in terms of consultations, it's likely that his consultations would be very focused on medication, symptoms, and physical care, instead of trying to promote his independence. Here we've got a very general care pathway where we will try to show you the pathway through the public system for a person living with dementia. So somebody would probably have concerns about memory or behavior, and 3 possibilities. We came up with 3 possibilities. The first one, these concerns would not be mentioned to any healthcare provider, or the concerns would be mentioned to a primary care doctor, or the concerns could be mentioned to a community health worker. In this case, the community health worker would just think that the symptoms are part of aging and would not mention to anybody else. Or he could mention these concerns to a primary care doctor. In this case, the primary care doctor could just think that it's part of aging and no more investigations would be made, or he could refer the person to a specialist doctor. In the stage of the specialist doctor, dementia could not be diagnosed and no further action in dementia would be taken, or could be diagnosed. In this case, the specialist doctor could just think that dementia is part of natural aging and no specific treatment would be prescribed, or he would educate a person about dementia and about the psychosocial care that this person could get, or the specialist doctor would just prescribe a drug treatment. In the case of treatments, the person with dementia could or could not follow the treatment that was recommended. Here we also have another care pathway for a person living with dementia but accessing the private service, the private system in Brazil. So somebody would have concerns about memory or behavior, and these concerns could not be mentioned to any healthcare provider or could be mentioned directly to a specialist doctor, a private doctor. So in this case, dementia could not be diagnosed and no further action would be taken, or dementia would be diagnosed and would be, after the diagnosed by the doctor, this specialist doctor could just think that it's natural part of aging, or he could educate the person about dementia, about the different therapies and psychosocial support that this person could get, or he could just prescribe a drug treatment. In this case of treatments, the person with dementia could follow or not the treatment, the recommended treatment. So in conclusion, we concluded that there is no national dementia plan or strategy in Brazil. Dementia symptoms are often faced as a natural aging process by the person living with dementia, their family and healthcare providers. Well-defined dementia care pathway, dementia care coordination system, and staff training and education in dementia are needed in Brazil. Socioeconomic status appears to be a determinant of access to dementia care, and people living with dementia and their carers lack support from the government and from the society. Thank you very much.
Thank you very much, Fabiana. That was super. And now we're going to go to the other part of the world again. This time we're going to go to Indonesia, and we're going to hear from Imelda Theresia, who's going to share with us an analysis of dementia policy stakeholders. The floor is yours when you're ready.
Hi everyone, my name is Imelda Theresia from STRiDE Indonesia. I will be presenting about analysis of dementia policy stakeholder in Indonesia as part of the STRiDE project. As an introduction and also the objective of the study, the STRiDE project aims to strengthen responses to dementia in developing countries and through new evidence inform the development or revision of the national dementia policies. To do this, STRiDE evidence needs to reach key stakeholders through appropriate channel and in a way that will effectively influence those stakeholders. Of course, to facilitate this, we are undertaking analysis to determine who are the key stakeholders and how to reach them, and developing knowledge exchange impact engagement activity, exploring how policy decisions are made in Indonesia. We're also exploring how policy decisions are made in Indonesia and what this means to impact from the STRiDE project. We are carrying out stakeholder mapping, social networking analysis. We also prioritize the stakeholder given the resources available with the project, identifying impact activity that are most appropriate for those stakeholders and implementing those activities. Like you can see from the mapping we already categorized all the stakeholders, and from this mapping, we could design the activity we do to achieve the impact. Preliminary stakeholder mapping was carried out to finalize participants of the Theory of Change workshop to inform the STRiDE project in Indonesia, and our activity has built on this. Based on our TOC map, Indonesia needs political will of the government to support National Dementia Plan that had established in 2015. To understand better the process of the Indonesian National Plan in 2015 development, influencing factor, and how evidence were and are used in the development and implementation, we need to do an interview with all stakeholders that involved in the drafting of the National Dementia Plan in 2015. This activity, we call it mini project, as part of the activity analyzing of dementia policy stakeholder in Indonesia. To do this, we use snowballing methods. Start from Alzheimer Indonesia. We interview Dewi Suharya as the contributor for National Dementia Plan. And we also interview Dr. Yuda Turana as academic researcher and also the research person for National Dementia Plan. We had interviewed 10 stakeholders that directly involved in the team developing National Dementia Plan 2015 and also other stakeholders as a current user of the National Dementia Plan. To identifying and recruitment respondent, like I said, that we use the snowballing method. We also mapping all the stakeholders based on their high power to the low power, and from the high interest to the low interest that you can see in the mapping. The high power and the high interest that we could see there are many Ministry of Health, Ministry of Social Affairs, and also Bappenas or Ministry of National Development Planning. Alongside this interview, we also want to understand the type of knowledge used in decision making and how this may affect our KEA plan. We also have a challenge to do the mini project, such as the question development. The question is too generic, so we need to adjust the role of the question to the role of each stakeholder. And also the scheduling time that we divide into two, the pre-COVID and the post-COVID. The before COVID, we finding it is difficult to do the face-to-face meeting because our respondent had a very busy schedule. But with the post-COVID or when the COVID happened, our stakeholder had grown used to do online meeting, and the time to do the interview, it is more flexible for them. And we also have a difficulty in doing the interviewing process, especially the post-COVID. When we invite them, it is a one-on-one interview, but several stakeholders invite their colleagues to join the meeting without informing us beforehand. So we had like 4 people in the Zoom meeting, and so we need to adapt the interview into the semi-focus group discussion setting, and it is require more time because there's more one person that we need to interview. And the highlight of this mini project that most of the stakeholders mentioned the use of the long-term national plan and also demographic data as a directive of what policy need to be prioritized. Use of the international and local study depend on the experts sitting in the committee, but patient or family experience is not yet as the key influencing factor. And we also planning to do the KEAE dissemination is by optimizing the use of Alzheimer Indonesia website and online activity to disseminate information from STRiDE, such as put information targeted to the general public as a article or e-booklet on our website. We also doing webinar to disseminate findings, such as the webinar for the chapter monthly meetings that also be used to build capacity for the regional chapter which want to do research, such as how to do FGD, interview with people with dementia and others. And we could also doing online caregiver meeting and also public webinar. As the conclusion, use of knowledge exchange strategy effectively based on the stakeholder that we already identifying so that there's a better understanding of the dementia, and use STRiDE data from the national recommendation amongst relevant stakeholders to increase their political will as the directive of their action. Of course, later in the project, we will also evaluating the impact as far as possible from the project. Thank you. And let's talk about dementia and our tagline in Indonesia, jangan maklum dengan pikun, do not underestimate memory loss.
Thank you so much, Theresia, and it's a fantastic overview from you and then before from all the colleagues on so much work that all of you have been doing in your countries on the STRiDE project. And I think now we're going to move to have a bit of a panel discussion. So now I'm handing over to Clara, and I think, Clara, you have some questions you have prepared earlier, as they say. So you'd like to take on?
Yes. So, let's start. So, can I just join Adelina in thanking all of you for those excellent presentations, and it was so insightful to hear about those many different aspects of the project and all those different learnings. And I thought there have been so many interesting topics that have come out from each of those presentations. So I'm glad that you're all here and we can have a bit of a conversation now. So can I start with a very broad question, actually? I would just be curious, and you've been working on this project for over 2 years now. What would you take away as the main learning that you have had since you've been working on this?
One of the main learnings that I've taken from the project thus far is just the importance of being on a research team with persons from multiple disciplines, because when you are going about a research project that's expected to have this level of impact, you have to have strength from so much different industries. And when you're on a multidisciplinary team, you also get the opportunity to learn from others with things that you might not have gotten the chance to learn in your past experience. And so I think just seeing how all of the work packages comes together to just really create an impactful change in our respective countries has just really been amazing, and just also shows the importance of teamwork and being open to learn, and just learning from other countries as well has really just been so important in my experience.
Thank you, Marissa. Anyone else who'd like to add anything to that question?
So thinking about Brazil and all the work that I've been doing, the work package 7, I think that it's really important it is something that came up to me. It's the need to have a national strategy for dementia care in Brazil. Because here we have got like many people with the disease, and but we don't have, it's not spoken, so it needs to be more spoken. We need to be aware, the population needs to be aware of the problem, as it is very impacting in terms of the people living with dementia and also the family carers and family as a whole. Yeah, it changes the family arrangements, and it's so important that we have the support from stakeholders, different stakeholders, and I can see this like starting to be live in Brazil, as we start to talk to people, and I think that it's going to be we are going to have a very good result, like in the end, working together with stakeholders and with research and trying to promote and disseminate dementia and the care strategy that's really needed in Brazil. Not only being treating dementia as part of older people strategies, but having something really specific for this condition.
Thank you, Fabiana. So, Saadiya, did you want to add anything?
Yeah. Yes, I think it's been a wonderful experience in terms of capacity building. And then one lesson I think as a team we learned is like we came from very different backgrounds, and the beauty and the charm was like we all are working as a team, coming as like, you know, researchers or AAs, you know, the NGO partners, and we have come to a conclusion where we have realized that there is a very strong need and the importance of an alliance between all the different domains for dementia. We've been working on very grassroots level, and we thought like this is it, this is how we should, you know, proceed. But then the project has taught us so much, where we have started exploring and thinking and changing our perspective. So yes, it's like shaping us, you know, in a better way. Yes, thank you.
Thank you,
Yeah,
Saadiya.
and I could also add something around partnerships, which in Kenya we have found that it is very, very key, right from inception of the project, midway, and even currently. And I mean, going to community settings without stakeholder engagement, without the necessary approvals, you could easily hit a snag. And for us, we realize it's very important when you get any grant funding, you quickly try and engage the relevant stakeholders, and partnerships are also important in making sure that they form part of the work, because they're the ones who are going to be part of policy development, buying of the project. And every stakeholder for us in Kenya is very, very key, starting from national stakeholders, regional stakeholders, gatekeepers, and everyone, including the participants, and they need to be equally engaged throughout the process.
Thank you, Christine. That actually brings me on to another question. Okay, or if Claudia or Roxanne, would you like to add anything to the previous question at this point? Then maybe I'll pose my other question, and if you want to add anything, you know, later, please join in. So one of the themes that I've picked up throughout those presentations that I think was very dominant in Marissa's presentation, but also in Saadiya's and Imelda's presentation, was this topic of communication. And Christine, and you've just highlighted that as well. And you spoke about the importance of communication, of bringing in stakeholders, of, you know, communicating with researchers in different countries, of communicating with people with dementia and their carers. Do you have any sort of top tips or any things that you would recommend, having had the insight that you now from working on this project, for sort of other projects or for working in the future?
Yeah, just a small thing, like I've been thinking, like, how much do we perceive, for example, like, involving a person with dementia in a big scale meeting. So there's a lot that is with our perceptions. I think we kept on, when I started, thinking about it, why we haven't done that so far. So I think somewhere we are trying to reach a very ideal situation. It's like, the most earliest of the diagnosis, so somewhere we have a huge picture that it has to be this way. But as we started doing things, as we started identifying people who would represent, and it became easy. So somewhere we realized that there was a lot about the perception or the ideas that we had. And then once you start doing it, you realize that, okay, it doesn't have to be like, exactly the picture that we have made. So that's about our idea, our experience that we felt.
Thank you, Saadiya. Imelda, do you have any recommendations and tips?
Yes, like you see that it is communication is become the big part of the project. And when we doing our TOC map, we invite all the stakeholders, and it is quite known in Indonesia, probably, and also others country, that each ministry they didn't work and talk each other. So with the STRiDE project, and also they're starting to communicate and discussing. And this is also like a positive side of the COVID, like because all the stakeholder is using Zoom meeting, and we have more and more meetings using Zoom, which all the stakeholders that I drew in the map, and hopefully we will get a result of it in doing the communication, and hopefully the result from the Work Packet 7 and also Work Packet 3 and others and Work Packet 5, they could use it to for it will become the national recommendation. So our political will from the government to raise awareness and to do more about dementia is appears like that.
Thank you, Imelda. One other question I had was, Roxanne, you spoke about cross-cultural adaptation, and I think, you know, just from the panel of people that we have here representing more than 7 countries, which is, it's really nice, and we get to speak a lot to each other, and usually communication is English, but then you take it away and the research is happening in so many different countries, and you spoke in quite a lot of detail about the complexities of translating that into other languages, and the use of different words and finding the right terminology. And Christine mentioned earlier as well the stigma that's surrounded, that dementia is surrounded with. What was your experience of working with that?
Thank you, Clara. I think one of the main learnings and gained from the experience of working on the Work Package 5 work, especially the pre-testing work, I think was the importance of actually spending time and resources on the cross-cultural adaptation process. I know it's from our experience, it's been rather time-consuming exercise. It's quite resource intensive, and perhaps for these reasons, projects tend to shy away from it. But I think it's something that is critical. It's a necessity if you want to use tools that are not developed for a particular setting. It's validated elsewhere, but if you want to measure something in a context, it has to be done culturally appropriately. So I think we followed quite a rigorous process in terms of forward and back translating, but we found an extra added value almost when we were picking up on the nuances and the underlying meanings more accurately when we were actually training the field workers on administering the tools during the pre-testing phase. They had a deeper insight into the context of the actual questions. So as a result, they ended up helping us refine the final version. So what we thought was a final version of the tool, after all of that translating forward and back and reconciliating, actually gone through another process of translating the tools. So it was refined even further. So we had like an unintentional another round of translation that kind of emerged from this process. Their inputs basically into the final version of the tools were bringing that final version in line with what the local understandings were, the local language use was for that particular context that we want to go and survey. So I think that was brilliant. So although we put a lot of thought into selecting our forward and back translators, we found that once we were working closely with the field workers, it added this other dimension. It was an important dimension, I think, that kind of just lifted the quality of the translation, and it really helped us make the tools, we can really say, culturally appropriate. Yeah.
Thank you so much, Roxanne. And I'm really excited about seeing what comes out of the study and the results of what you will find. As we're sort of preparing preparing for this very detailed work in a couple of countries. We have, Claudia, you mentioned some details about the issue that is around the epidemiological information that's available in Mexico. Do you want to highlight some of the points of, around that work?
Yeah, thanks, Clara. I would like to add about this information that I had presented, that it's so important to develop the abilities of searching to the epidemiological data, but it's more important to interpret to this data and to translate to the evidence to stakeholders. So this, the data is only a part of this process. So we have to translate this information in order to take evidence or to the stakeholders to develop systems, better health services to the people with dementia.
Thank you very much. And that actually leads me very nicely to, again, a broad, but my final question, which is, you've been working on this project for a couple of years now, and I know there's a lot of that will be happening and a lot of data still be happening and analysis to be conducted. But from all the learnings that you've had so far, what do you think should be key priorities in each of your countries to bring dementia on the policy agenda and to enable people with dementia and their carers to live well?
I think decision makers and people working at the grassroots level are very important. And I would say we engage policy, and we can use different methods of engagement. We could use evidence based on STRiDE work. We could use evidence summaries packaged into policy briefs. We could also use workshops, and we have national advisory group workshops in each country. We have international advisory group for the big STRiDE team. And so those are some of the avenues that we could use to engage policymakers so that they can buy in, and so that when we are translating research into policy, it is likely to be a seamless process when we engage.
Thank you very much, Christine.
I could say from South Africa's side, I think what will be useful is policymakers need something concrete to make decisions on, especially dementia-related decisions. And where there's a lack of evidence and data, we need to strengthen those systems so that we can actually give them the evidence and say, look, if you intervene, this is the outcome. If you don't intervene, the outcome is potentially worse. So it's to improve the data systems for South Africa, number one. Number two, I'd say, is inclusion. It's so important to include people who has the experience. They are the experts, basically. They live it every day. And one intervention is not something that you can cut and paste across context. So the people that you want to reach, the people you want to intervene, the people you want to improve their lives, they need to be part of the process. And I think that's something that's a key component of what STRiDE is doing, but it's something we have to roll out beyond STRiDE as well, not just for the work that we're doing in our countries for the time period of this project, but going forward, that their voices need to be first and foremost before consulting any other experts on what is best for them.
Thank you, Marissa. Thank you very much. Any other final thoughts? Maybe Adelina or Margie would have anything to...
Margie?
Yeah, maybe just to add that certainly one of the things I've learned from the project is how similar situations and issues are across the countries. They play out in culturally specific ways in the countries, but the issues are the same. The issue of stigma, the issue of isolation, the issue of lack of evidence, all those things, and lack of planning around dementia is something that's very much the same across the 7 countries. And I think I found that actually really interesting, and the ability to share all of that together is really useful and helps plan a more effective plan for middle-income countries, for developing countries, by bringing all this information from already 7 countries. So that's just a couple of thoughts.
Thank you.
And for me, just to say that I'm absolutely amazed by how much you have all achieved in these last few years. And despite all the challenges of working remotely and adapting to working with each other and you know, all these practical barriers we've faced in the process, I think it's absolutely fantastic. And I'm going to take home this engage message, because I think that is really what's going to be crucial, as well as the quality of our work, to make sure that all this research leads to some change. Thank you very much. And also thank you, Clara, for excellent co-chairing and fantastic questions. And well done, everyone. Thank you.